Hello, and thank you for coming to view my presentation. Today, we're going to be discussing the efficacy and safety of triple therapy in the initial management of hypertension. Specifically, we're going to take a look at the use of fixed-dose combination products for initial hypertension management. Our learning objectives for today will be to define the current standards of care for hypertension, to evaluate the literature on the safety and efficacy of triple therapy in hypertension management, to evaluate the cost effectiveness of fixed dose combination products, and finally, to develop a recommendation for the use of fixed dose triple therapy in initial hypertension management. Some background information on hypertension. Around 108 million adults in the US have hypertension. This is defined as a systolic greater than 130 millimeters mercury or a diastolic blood pressure greater than 80 millimeters mercury, or are taking medication for hypertension. This adds up to about 45% of the United States adult population. Of these patients, only 24% have their hypertension under control. And of all adults with uncontrolled hypertension, 45% have stage 2 hypertension with a systolic blood pressure greater than 140 or diastolic blood pressure greater than 90. This all adds up to cost the United States around $131 billion every year in healthcare costs. To review the management of hypertension, we're going to look at the 2017 Journal of the American College of Cardiology guidelines. They state that patients with stage 1 hypertension, or again a blood pressure greater than 130/80, should be managed with non-pharmacological therapy. However, if patients have stage 1 hypertension and an ASCVD risk score of greater than 10%, they should be managed with non-pharmacologic therapy and one hypertensive drug, antihypertensive drug. Patients with stage 2 hypertension or a blood pressure greater than 140/90 should be managed with non-pharmacological therapy and 2 agents of different classes. Agents recommended by the JACC include ACE inhibitors, angiotensin receptor blockers, thiazide diuretics, and calcium channel blockers. We're going to take some time real quick and review the mechanism of action for each of these classes. Calcium channel blockers block L-type calcium channels in the cardiac and smooth muscle cells to block the entrance of calcium into the cell. This results in increased arterial vasodilation. ACE inhibitors and angiotensin receptor blockers both work on the renin-angiotensin-aldosterone system. ACE inhibitors block the conversion of angiotensin 1 to angiotensin 2, and angiotensin receptor blockers block angiotensin 2 from binding to its receptor. This results in decreased vasoconstriction, aldosterone secretion, and catecholamine release, and increased vasodilation. Finally, thiazide diuretics work to inhibit the renal sodium chloride cotransporter, which causes sodium depletion and plasma volume reduction. Each of these mechanisms work individually to decrease blood pressure, but if only one mechanism is activated, then the renin-angiotensin-aldosterone system can compensate and decrease the effectiveness of these medications. By using multiple medications together, we can lead to a greater decrease in blood pressure than by using individual medications by blocking that compensatory response. This is why the JACC states that stage 2 patients should be started on 2 agents of different classes. Agents chosen should be chosen by patient-specific factors, such as level of adherence, patient age, any comorbidities the patient has, and cost of therapy. Many patients who are started on one agent will eventually need 2 or more agents. Because patients will eventually need 2 or even more agents, a question exists that could patients be started on 3 agents with complementary effects to get the maximum amount of blood pressure lowering by blocking all 3 compensatory effects. One question that this could raise is as adding more medications could increase the level of non-adherence in a patient, which leads us to triple combination pills, which combine 3 drugs of different classes to utilize that maximum complementary effect on the renin-angiotensin-aldosterone system. Current triple combination pills in the United States that are available use an angiotensin receptor blocker, a calcium channel blocker, and a thiazide diuretic. Available agents in the US include valsartan or olmesartan for the angiotensin receptor blocker, and both combinations use amlodipine for the calcium channel blocker and hydrochlorothiazide for the thiazide diuretic. Now, of course, when we're considering using 3 agents for initial management of hypertension, we have to consider, is this safe for the patient? Starting with 3 different drugs could result in increased adverse events such as hypotension. So we're going to look at a study that looks at the use of triple therapy for hypertension management, not necessarily in initial care, but first we're just going to get that baseline, make sure that using a 3-drug combination tablet is safe in patients. So the first study that we're going to look at is safety and effectiveness of a fixed dose combination of olmesartan, amlodipine, and hydrochlorothiazide in clinical practice from Bramlage and al. This was a prospective observational study conducted in multiple primary care centers across Germany and Austria. It was a non-interventional study that followed patients taking a combination tablet of olmesartan, amlodipine, and hydrochlorothiazide over 24 plus or minus 2 weeks. The objective of this study was to determine the safety and efficacy of a fixed dose combination pill in clinical practice, with an emphasis on safety according to age, cardiovascular risk, and additional medications. Outcomes included any documented adverse drug reactions during the trial period that were attributed to the fixed dose combination tablet. Serious adverse drug reactions were also included, these being death, life-threatening reaction, inpatient hospitalization or prolonging of existing hospitalization, any persistent or significant disability, any medically significant reaction, or congenital disease or birth defect. The study also measured efficacy as a mean of 3 sitting blood pressure measurements. The study included any adults age 18 or over who were diagnosed with essential hypertension and who began a fixed dose combination tablet within 2 weeks of their baseline study period. Patients were excluded if they had impaired renal function, including hypokalemia, hypercalcemia, hyponatremia, or symptomatic hyperuricemia. The patients were also excluded if they had impaired liver function, including cholelithiasis or biliary tract obstruction. Patients were excluded if they had one of several cardiovascular problems, including severe hypotension, cardiogenic shock, left ventricular obstruction, or if they had hemodynamically unstable heart failure after acute MI. Patients were also excluded if they were being treated with aliskiren, and finally, if they had any planned or current pregnancy. The mean age of this patient group was 63.5 plus or minus 11.79 years, and 53% of the patients were male. They had a baseline BMI of 29.4 plus or minus 4.89 kilograms per meter squared, and 36.9% of these patients were obese with a BMI greater than 30. 70% of these patients had at least one CV cardiovascular risk factor, with 54.7% having 1 to 2 risk factors and 10.2% having 3 or more. The most common of these risk factors was diabetes at 29.4% of patients, followed by metabolic syndrome and smoking. The study included any patients who were on any one of these combinations of olmesartan, amlodipine, and hydrochlorothiazide. 5,831 patients were enrolled and included in the safety set, and 5,818 patients completed all efficacy measurements and were included in the full analysis set. So for results of the safety analysis, 1.23% of patients had at least one adverse event during the study period. They were recorded by primary organ system, with 0.6% of patients having a general disorder, with the most common of those being 0.3% having peripheral edema, 0.19% having a skin or subcutaneous tissue disorder, 0.17% having a nervous system disorder, with the most common disorder of those being dizziness at 0.12%. 0.15% of patients had a vascular disorder, with the most common of those being hypotension at 0.14%. And finally, 0.10% of patients had a gastrointestinal disorder. 0.09% of patients had any one of the serious ADRs, and 0.82% of patients had an ADR that led to the discontinuation of their fixed dose combination tablet. Here you can see the rate of ADRs in patients according to different groups. The first being age. 1% of patients less than 65 years old had an ADR versus 1.4% of patients greater than 65 years old. For patients with diabetes, 1.5% of patients who did not have diabetes had an ADR versus 0.7% of patients with diabetes. Patients with low cardiovascular risk had ADRs at a rate of 1.3% versus patients with high cardiovascular risk at 1.0%. And finally, patients with any additional medications had ADRs at a rate of 1.4% versus patients who only took the fixed dose combination tablet who had ADRs at a rate of 0.7%. Both the systolic and diastolic blood pressure decreased over the trial period. The mean change in blood pressure was 28.8 over 13.9 millimeters mercury. 5.1% of patients had a blood pressure less than 149 over 90 at baseline, and this actually increased to 67.5% at follow-up. So what can we conclude from this trial? This has showed that there has been a relatively low rate of adverse events in these patients taking triple drug combinations, even among elderly patients, patients with diabetes or cardiovascular risk factors, and patients on any additional medications. It had a relatively broad inclusion criteria, which allows for generalizability to a normal patient population, apart from those excluded criteria, particularly the renal, hepatic, and cardiovascular excluded patients. And the efficacy data just served to back up some data from other clinical trials. Showed that two out of three patients during the trial achieved blood pressure control less than 140 over 90. For us looking at triple therapy, it has shown that this was safest in younger patients with less medications. Some limitations from this trial include the fact that it was a prospective observational trial, and it lacked adjustment for any confounding variables. For example, patients could be taking other antihypertensive medications other than aliskiren, or any of the other effects other medications may have had on the outcomes. It was a Central European patient demographic, which might not translate the best to US patient population. And finally, the adverse event reporting may not have been as complete as if it was a clinical trial. However, this may better represent a normal patient population. Other limitations from this trial to initial therapy include that it's really not applicable to what we're looking at in regards to initial therapy, and it wasn't compared to any other medications. But I think that it gives a good background safety measure on the use of triple therapy or 3 agents in hypertension management. So that last trial provided us pretty limited data on efficacy. So the next trial that we're gonna look at is gonna focus on the efficacy of triple therapy in how well it can reduce blood pressures. The study that we're gonna look at is triple antihypertensive therapy with amlodipine, valsartan, and hydrochlorothiazide, a randomized clinical trial from Calhoun and al. This was a randomized double-blind control trial that was conducted across 15 countries. It compared a triple combination of amlodipine, valsartan, and hydrochlorothiazide with dual therapy combinations of each of the components, meaning amlodipine, valsartan, valsartan hydrochlorothiazide, and amlodipine hydrochlorothiazide. The objective of this trial was to evaluate the efficacy and safety of triple therapy, valsartan, amlodipine, hydrochlorothiazide, with the dual combinations of each of its components in patients with moderate to severe hypertension, which was defined as a mean sitting blood pressure of greater than 145 over 100. Efficacy outcomes included the mean sitting systolic and diastolic blood pressure and the change in systolic and diastolic blood pressure from baseline. Safety outcomes included adverse events, serious adverse events, which in this trial meant adverse events that caused discontinuation of the study medication, and any hematological or biochemical laboratory parameters. Patients were included if they were adults aged 18 to 85 diagnosed with hypertension, with a systolic greater than 145 and diastolic greater than 100. Patients were excluded if they were women who were not postmenopausal for at least 1 year, surgically sterile, or using non-hormonal birth control. Patients were also excluded if they had cardiovascular comorbidities, if their serum sodium was less than 132 millimoles per liter, or their potassium was less than 3.2 millimoles per liter, or if they were taking any other medications that could affect their blood pressure. Patients were also excluded if they fell into one of these 4 groups. Any patients who were on 4 or more antihypertensives, any patients who are on 3 antihypertensives with an uncontrolled blood pressure of greater than 140/90, any patients who are on 2 antihypertensive with a severe uncontrolled blood pressure of greater than 180/110, or any patients who were not on any antihypertensives and were uncontrolled prior to start of the trial. This is significant for us as we are still looking for that initial management. However, we're going to use this study to back up the efficacy results for triple therapy in just general hypertension management. The mean age of the patient group was 53 years, with 86% of patients being less than 65 years old. 55.3% of these patients were male, and the blood pressure at baseline was 169.9/106.5. 10% of these patients were diabetic, and all reported subgroup characteristics were similar between the treatment groups. You can see here, this is a diagram of the outline of the study. Patients were first enrolled in a single blind placebo run-in period, during which they discontinued their previous antihypertensive therapies and were started on a placebo medication. At week 1, patients were then started on their assigned groups, with this line here at the bottom being the triple therapy group. You can see that it was titrated, the medications were titrated up over time, and the triple therapy group actually started triple therapy at week 2, as they did not start the amlodipine during week 1. By week 3, all patients were on the study dosages of their assigned groups. Of 4,285 patients enrolled to the placebo run-in, 2,271 were randomized and 2,060 completed the study. The most common reason for the discontinuation from the placebo run-in period was that they no longer required their study drug. And the most common reason for discontinuation from the study was adverse events at 3.1%. The intent to treat population included 2,236 patients, and the safety analysis included 2,268 patients. You can see here, there was a greater percentage of patients who achieved their target blood pressure by the end of the trial in the triple therapy group than in any of the dual combination therapies. They also had a greater decrease in both systolic and diastolic blood pressure. The percentage of patients who experienced at least one adverse event was pretty similar between all the trial groups. The percent of patients who experienced dizziness was higher in the triple therapy group and the valsartan hydrochlorothiazide group versus the amlodipine valsartan and the amlodipine hydrochlorothiazide group. Whereas the percentage of patients who experienced peripheral edema was lower in the triple therapy group and the valsartan hydrochlorothiazide group than in the amlodipine valsartan group and the amlodipine hydrochlorothiazide group. The serious adverse events occurred in less than 1% of the total population and occurred at similar frequencies between groups. Laboratory changes were also similar between groups aside from potassium, which was decreased in all groups that received hydrochlorothiazide and increased in the amlodipine valsartan group. So conclusions from this trial. Triple therapy was more effective than all of the dual therapy combinations in mean blood pressure reductions, as well as the percentage of patients who achieved their target blood pressure goal. It was well tolerated and it had a pretty similar adverse effect profile to the dual therapy groups. A high number of patients did wash out during the placebo run-in period. However, the study did still meet power. It excluded patients with cardiovascular comorbidities, which does limit its applicability to real-world patients. And it was funded by Novartis, and many of the investigators were employed by Novartis or had received grants from Novartis. In addition, this specifically excluded any patients who would not be using this for initial management, but I think it gives a good outline of how this is effective for patients, more effective than just using two medications. So finally, the next study the previous studies that we have reviewed so far have not been applicable to initial management of hypertension. We've seen that it's been safe for use in normal hypertension patients and has also shown more effectiveness than only using two medications. But now we're going to look at a study that specifically looks at the use of 3 medications as initial management for hypertension. Study that we're going to review is fixed low-dose triple combination antihypertensive medication versus usual care for blood pressure control in patients with mild to moderate hypertension in Sri Lanka, a randomized clinical trial from Webster et al. This was a randomized open-label control trial conducted in Sri Lanka that followed patients over a course of 6 months. It evaluated the use of low-dose triple therapy versus usual care prescribed by patients' normal prescribers for initial management of hypertension or those uncontrolled on monotherapy. The primary outcome was the percentage of participants who achieved their blood pressure control of less than 140/90 at 6 months. The target blood pressure for any patients with diabetes or chronic kidney disease was less than 130/80. Secondary outcomes included the percentage of patients who achieved their target blood pressure at 6 and 12 weeks, the mean change in systolic and diastolic blood pressure, self-reported adherence, which was defined as taking all prescribed antihypertensive medications at least 4 out of 7 days per week, and finally, intolerance to treatment at 6 months, which was defined as discontinuation of their antihypertensive therapy due to adverse events. Patients were included if they were, again, adults aged 18 and older with persistent hypertension, which was defined as blood pressure greater than 140/90 or 130/80 in patients with chronic kidney disease or diabetes. Patients were excluded if they were currently being treated with 2 or more antihypertensive medications. If they had any severe hypertension, which was systolic greater than 180 or diastolic greater than 110. Any accelerated hypertension or physician-determined need for slower hypertension therapy titration, any unstable medical conditions that could cause their hypertension regimen to be altered for any significant amount of time, any clinically significant abnormal lab values, and finally, any pregnant patients or patients of childbearing potential without any adequate contraceptive. The mean age of this patient group was 56 years, with 58% of these patients being women. 29% of patients had diabetes, and 41% of patients were on an antihypertensive medication prior to randomization. This shows that about 60% of patients were using this triple therapy as initial therapy, whereas 41% had only been on one medication prior to use. They may have had a lower blood pressure or at baseline, or they could have fit into the stage 1 hypertension group, according to the JACC. The mean baseline blood pressure for this patient group was 154/90, and other characteristics were similar between both groups. Patients were randomized to either receive a combination of telmisartan, amlodipine, or chlorthalidone at low doses, with a higher dose option being available for titration if the physician wanted to increase them, or to receive usual care under the guidelines of their physician. The study runners made no attempt to influence the treatment of patients in the usual care group. They just they went to their doctors and got their hypertension treated as normal. 700 patients were randomized, with 349 being placed in the fixed dose combination group and 351 being placed in the usual care group. 318 patients were included in the final analysis for the fixed dose combination, and 329 were included in the final analysis for the usual care. Patients who were lost to follow-up had either withdrawn their consent or had not completed their in-person blood pressure checks. The final analysis only included all patients who had completed all blood pressure checks as outlined in the study. You can see here, this is just a chart that shows how many medications patients were on at any point in the trial. You can see about 60% of the triple combination group were not on any medications prior to study, and some were on one medication. And then for most of the trial, the triple therapy, that was all they were using. Some patients were decreased, whereas for the most part, usual care only used one medication, with more medications being added on over time. So for the results of this study, the fixed dose combination group had a significantly greater percentage of patients who achieved their target blood pressure at 6 months, as well as at 6 weeks and 12 weeks. They also had a greater decrease in systolic and diastolic blood pressure than those in the usual care group. The percentage of patients who met their self-reported adherence was similar between both groups, and it was both very high. The self-reported adherence measure was a little weak. Again, patients only had to take their medication 4 out of 7 days per week, and it was self-reported. And the percentage of patients who withdrew due to adverse events was also similar between both groups. The percentage of patients, you can see here the percentage of patients who reported at least one adverse event, as well as some specific adverse events, most notably being dizziness, syncope, or pre-syncope at 5.2% versus 2.8%. So conclusions from this trial, a significantly greater percentage of patients achieved their blood pressure goals in the triple therapy group versus the usual care group. They also did this faster, with the greater percentage achieving at the 6 and 12 week mark compared to the usual care group. It also showed that there were no significant differences in adverse events or their self-reported adherence. Notably, only 3% of patients in the triple therapy group switched to the higher dose version of the tablet that was available for titration, which showed that they achieved these blood pressure goals without having to use the higher dose of the tablet. Limitations of the trial, as mentioned, only 41% of the participants were already on an antihypertensive medication. The study was also conducted in Sri Lanka, so it may not be as applicable to a US population. The design of the usual care versus the fixed dose combination made it so that they kind of had to do an open label trial, could have introduced some confounding variables. And finally, the drugs utilized in the triple combination pill, the telmisartan and the chlorthalidone, are different than what's currently available on the market in the US. However, they are the same classes as what's available in the US, the thiazide diuretic and the angiotensin receptor blocker. So now just to go over real quick some cost benefit of the triple combination tablets versus their components. What I have here is each of the available combinations of olmesartan, amlodipine, and hydrochlorothiazide, and valsartan, amlodipine, hydrochlorothiazide. This is the average wholesale cost of the individual tablets for both olmesartan and valsartan, as well as in the middle is the individual costs for each of the components. So the olmesartan component, the valsartan, and then the amlodipine and the hydrochlorothiazide. On the right here is the total of the average wholesale prices for each of the individual components, which we're going to compare to the wholesale price of the combination tablet. In general, It's cheaper to use the combination tablet for patients who are on olmesartan or are going to be using olmesartan as one of their medications, especially if they're going to be using 3 medications for hypertension management, whereas valsartan is generally cheaper to just use individually. So cost benefit of using triple combination products. Of course, when you are going to increase from, say, 2 drugs to 3 drugs, there's going to be an increase in cost associated with that. But in general, the fixed dose combination products are cheaper than the sum of their components for olmesartan at least. Also, there could be a lower prescription fee cost for patients, depending on their insurance, if they only have to fill 1 combination tablet versus 2 or 3 other medications. So finally, looking at all the data, we have seen that triple therapy has been shown to decrease blood pressure more effectively and faster than usual care. Overall, adverse event rates are similar and relatively low when using triple therapy. I think that triple therapy can be used, low-dose fixed combination pills can be considered an option for initial management of patients in a very specific population, that being those with a stage 2 hypertension, blood pressure greater than 140/90, any adult non-pregnant patients based on the trials, as well because many of the trials excluded patients with significant comorbidities. I'm hesitant to use triple therapy in these patient groups, specifically renal, hepatic, or cardiovascular comorbidities. And finally, I think it would be safer to use in younger patients on less medications, as we saw from the safety study that we looked at. The rate of ADRs was lower in patients under 65 and patients not taking any additional medications. In the future, I would like to see studies that focus on adherence with fixed dose combination pills versus normal therapy, to see if that has a benefit in adherence, as well as studies that look at long-term safety of patients on 3 medications for hypertension. And finally, an in-depth cost-benefit ratio analysis to see if there are any healthcare savings through more effective blood pressure control associated with triple therapy. And I would now like to open it up for any questions. And thank you all for listening to me today.